Hello and welcome to video tutorials on fluid management developed by URC with funding from USAID. Fluid management is very important, essentially in acutely ill patients, and in this video we will address some key points of correct fluid management in common clinical scenarios. The objective of this video is to discuss maintenance fluid and how to calculate it for individual patients, as well as fluid balance and its calculation. Finally, IV fluid management in emergency scenarios. Maintenance fluid is the minimum amount of fluid in the body needs in order to maintain all its normal functions in a 24-hour period. This depends on the size of the persons and how much fluid they lose in a day, but in adults it's normally somewhere between 2 to 3 liters a day. In children, we can calculate maintenance fluid using the child's weight. Wherever possible, oral fluids is preferred to IV fluids, especially in children whose immature kidneys are less able to manage big changes in electrolytes. Studies have shown that there is no difference in clinical outcome between children who are dehydrated from gastroenteritis between oral and NG fluid replacement rather than IV. However, IV fluids have the added risk of infection and phlebitis and can result in serious life-threatening sodium imbalance if not administered and monitored correctly. IV fluid, like all medication, should only be prescribed for patients where absolutely indicated. To calculate a daily IV fluid maintenance for children, we must first know their weight. If child weighs 10 kilos or less, then the maintenance calculation is 100 ml multiplied by the weight in kilo. This is the amount of fluid given to a child over a 24-hour period. If the weight between 10 and 20 kilos, the maintenance calculation is 1000 ml. That means 100 multiplied by 10 for the first 10 kilos plus 500 ml multiplied by the amount they weight between 10 to 20 kilos. If the child weighs over 20 kilos, the maintenance calculation is 1500 ml. It means 1000 ml for the first 10 kg, 50 multiplied by 10 for the next 10 kilos, and plus 20 ml per kilo of the weight about 20 kilos. The maintenance fluid choice in children in half-normal saline, 50 dextrose. Now let's practice this formula with some real clinical cases. A 10-month baby presents with hand, foot, and mouth disease. Due to their ulcerated, painful mouth, they are reluctant to take any oral fluids at all. They weigh 7 kilos. How would you calculate their daily maintenance IV fluids? Using the formula 100 ml multiplied by 7 kg equals 700 ml a day of half normal saline 5% dextrose. A 9-year-old girl presents with symptoms of appendicitis and is being kept knelt by mouth while she waits for surgery. She weighs 18 kg. How would you calculate her maintenance fluid? Using the formula 100 multiplied by the first 10 kilos plus 50 multiplied by the next 8 kilos equal a total 1,400 ml over 24 hours of half normal saline 5% dextrose. A 33-year-old is admitted to the ward with Japanese encephalitis and unconscious with loss of gut reflex. Her GCS is 7. She weighs 22 kg. How would you calculate her maintenance fluid? $100 ml for the first 10 kg, 500 ml for the next 10 kilos, plus 20 ml multiplied by 2 kilos. This equals a total of 1,540 ml of half normal saline 5% dextrose a day. A 24-year-old man with head injury and a GCS of 8 is unable to protect her airway, so is being kept knelt by mouth. Her weight is 65 kg. What IV fluid maintenance would you give him for 1 day? The average amount of fluid an adult males need is between 2 to 3 liters a day. However, the maintenance formula for children can also be used for adults if you want to calculate more accurately. 100 ml for the first 10 kg plus 500 ml for the next 10 kg plus 20 ml multiplied by 45 kg equal a total of 2,400 ml in 24 hours. Adult maintenance fluid can be normal saline or lactating juice. Key points to remember about maintenance fluid are that the oral route is preferred whenever possible, and IV fluids should only be given to patients when absolutely clinically indicated. Adults need between 2 to 3 liters of fluid a day, if either normal saline or lactating juice. Children's maintenance can be calculated using a formula based on their weight in kilos. 100 ml per kilo for the first 10 kg, 50 ml per kilo for the next 10 kilos, between 10 to 20 kilos, and then 20 ml per kilo for anything about 20 kilos. Half normal saline and 50% dextrose is commonly used as maintenance in children. Next, let's consider fluid balance. What patient do you think require fluid balance recorded and calculated. Patients with signs of fluid imbalance will need fluid balance recording. This can be patients with signs of fluid overload such as in cardiac or renal failure, or those patients with signs of fluid depletion such as those that are dehydrated or shocked. Any acutely ill patients should have fluid balance calculated to look for any sign of fluid imbalance. Patients who are pre or post-op or those who are nil by mouth or require fluid balance recording and calculating. Fluid balance is an important method to monitor the patient's circulation system and renal functions. In order to do it correctly, we must measure, record accurately all the fluid goes into a patient. We also need to measure, estimate, and record as accurately as possible all fluid that comes out of a patient. So, what fluids in should we be measured and record in the patient nursing notes? All oral fluid taken needs to be recorded. IV fluids, including any medications and blood transfusion or other blood products that are given, anything that are given down, and tissue feeds. What fluids out should be measured or estimated as accurately as possible? Urine output from a catheter or if the patient is voiding normally, we need to collect and measure. In other, we would expect normal urine output to be 0.5 ml per kg per hour. In children or sick patients, you would aim and expect to see urine output of 1 ml per kg per hour. An accurate estimate of vomit or NG aspirate needs to be made and recorded. As does any watery stool or loss from a stoma or fistula. Normal stool is included in insensible losses. If patient had surgery done any loss from drains need to be measured. It is important to try to estimate as accurately as possible blood loss from trauma or perioperatively. Insensible losses is the fluid loss that cannot be measured, which includes sweat, estimated to normally be roughly 500 ml a day, fluid loss from a lungs on expiration 400 ml in a day, and normal stools 100 ml. In normal 20 kilo adult, this is estimated to be roughly 1000 ml a day. In children, insensible losses can be calculated using 400 ml per square meter. To calculate fluid imbalance, we must add up all fluid going in during a 24-hour period and then subtract a total of the fluid coming out in that same period. We shouldn't forget to include an estimate of insensible losses. Use the body's fine system of hemostasis. The fluid balance equation should be zero, but in reality, because it is hard to estimate correctly the amount of insensible losses, it often comes ought to be slightly positive. Fluid balance should be calculated daily, and the management of patient review with the result. Let's now do some examples of fluid balance calculation and see how it can affect patient management. The first example is a 40 kg woman who ruptured her splint in a motor accident and has had surgery to remove her splint. She is 1 day post-op. Fluid in the last 24 hours have been 1 liter of normal saline, 4 units of blood. She has been nilled by mouth. Her blood out in the same time period have been urine from her catheter 300 ml, 500 ml of gastric aspirate from her NG, an estimate 1,500 ml of blood, and a further 500 ml from the drain after surgery. Her insensible losses were estimated to be roughly 1,000 ml. How would you calculate her current fluid in? How would you calculate her current fluid balance? If the exact amount of milliliters of blood has not been documented in the notes, we can estimate that each unit of blood is roughly 300 ml. So for this patient, the fluid in are 1 liter of saline plus 1,200 ml of blood transfusion, which equal 2,200 ml in total. For fluid out, we add 300 ml of urine, 500 ml of NG aspirate, 1,500 of estimated blood loss, 500 ml from her drain, and estimate 1,000 ml for her insensible losses, which gave us a total 3,800 ml fluid out. So 2,200 minus 3,800 gives us a negative fluid balance of minus 1,600 ml. A negative fluid balance means that the patient is fluid depleted or dehydrated. How would the patient present if they are fluid depleted? When someone is fluid depleted, they will feel thirsty and want to drink water. The patient's skin may have reduced vigors as the fluid in the interstitial space is depleted. They may have dry mucous membranes. If there is a large fluid depletion, they may have signs of cardiac compensation with tachycardia, reduced capillary refill time. The blood pressure will remain compensated and normal until they have lost a significant amount of intravascular fluid. Low blood pressure is a very late and pre-terminal sign, which is why it is important to look for other clinical signs and not just depend on blood pressure. When the body is fluid depleted, the kidney will filter less fluid and try to remain fluid. If they are working normally, normal urine output should be between 0.5 and 1 ml per kg per hour. So measuring our urine output is very sensitive way to detect early if there is a fluid balance. Concentrated urine will be less than 0.5 ml per kg per hour and will be dark in color. That would be your fluid management for the next 24 hours for this patient post-splenectomy. What would be your fluid management for the next 24 hours for this patient post-splenectomy? This patient needs maintenance fluid as he is the nil by mouth still. It means he did not eat anything. At he weighs 40 kg, this will be 1000 ml for the first 10 kg, 500 ml for the next 10 kg plus 20 ml multiplied by 20 kgs, which is the total of 1900 ml of normal saline or just like that for the next 24 hours. She also needs the fluid deficit replacing, which will be an extra 1600 ml over the next 24 hours. If her post-operative FBC shows, that means if the post-operative complete blood count shows hemoglobin of less than 7 grams per deciliter, or she is continuing to accumulate, some of this replacement fluid will need to be in the form of blood transfusion and the rest as normal saline. And if the hemoglobin is about 7 grams per deciliter, she is not bleeding, then it can replace with normal saline or ringer lactate. Any ongoing losses from antitube and drains should be replaced regularly rather than wait for 24 hours for large fluid deficit to develop. Replacement fluid is normal saline or ringer lactate, as this is the same amount of sodium in it as the body fluid. In this second example, we have 17-year-old girl who is in supraventricular tachycardia at the rate of 200 per minute. That has been untreated for 2 weeks. As a result, she is now in cardiogenic shock and has acute renal impairment. She weighs 50 kg. Her fluid in the last 24 hours has been 500 ml orally, 2 liters of IV fluid. Her urine output was been 200 ml of dark concentrated urine for the last 24 hours. We mustn't forget her insensible losses. Can you calculate her fluid balance? Her fluid is 500 ml oral plus 2000 ml IV, which is equal to 2500 ml in total. Her total fluid out is 200 ml of urine plus 1000 ml estimated for insensible losses, which equal 1200 ml. So the fluid balance equation is 2500 ml in minus 1200 ml out, which gives us a positive fluid balance of 1000 ml. A small positive fluid balance is often seen in patients mainly because clinicians will often underestimate the insensible losses. If a patient has a true positive fluid balance, then they have fluid overload. Severe fluid overload can present with dependent edema, a raised jugular vein pulse, GVD, a sign of pulmonary edema, shortness of breath, fine basal crepitation on auscultation, and if chronic pleural effusion, ascites, and hypertension. The management of fluid overload depends very much on identifying and treating the cause. For this patient with heart failure and acute renal impairment secondary to her tachyarrhythmia, the first step is to treat SVT with DC cardioversion or, if not available, chemical cardioversion with drugs. If the patient is fluid overloaded due to congestive cardiac failure or chronic renal failure or associated with hyponatremia, then we can restrict their oral intake to less than 2 liters a day. If we fluid restrict, we also need to closely monitor fluid balance, weight, and blood electrolytes. Diuretics are not always indicated in congesting heart failure. They are indicated and helpful for treatment, but if the patient has acute renal failure or is in heart failure due to precardial effusion, then they are not indicated and have been shown to worsen renal function. This is why it is important to always try to find the cause of a patient's fluid imbalance. The key points regarding fluid balance are that we must measure and record all fluids that goes into patients, oral, NG, and all IV fluids and medications. We also must measure as accurately as possible and estimate all fluids that goes out of the patients. This is a lot harder to do in practice. The fluid balance equation is the total fluid in minus of total fluid out. That means the total fluid in minus the total fluid out. It is important to not forget about an estimate for insensible losses when we are doing the daily fluid balance equation. IV fluids are indicated in emergency situations if there are signs of circulation problem. Shock is not just a low blood pressure, and in fact, there are many earlier signs of shock before the blood pressure drops. These include sinus tachycardia, cold breathing, delayed capillary refill time, pallor, reduced urine output. Hypotension and arterial mental status are late indicators of shock and should not be relied on when making a clinical diagnosis of shock. Common causes of shock are hemorrhage, sepsis, severe allergic reaction, anaphylaxis. IV fluids are also clinically indicated for patients who have the potential to develop a circulation problem such as burns, a patient who is bleeding with no clinical sign of shock, a patient who is not taking or is unable to tolerate oral fluids, for example, if the case of persistent vomiting. This 35-year-old multipara woman, bleeding postpartum, and her estimated blood loss is over 800 ml. She weighs 55 kg. Her vital signs are heart rate of 120 per minute, blood pressure of 80 over 50, respiratory rate 24 per minute, and temperature is 36. What initial emergency fluids would you give her and how much? This patient has signs of shock because she is tachycardic and hypotensive. Hypotensive. This needs immediate attention. Fluid resuscitation in bleeding patients starts with the insertion of at least 2 large bore cannula. A fluid bolus of 1 liter of either normal saline or ringer latex is the appropriate first-line treatment. After giving the bolus, we need to reassess the patient's circulation status, and if there are still signs of shock, we should immediately give a second fluid bolus or saline or ringer latex. In shock bleeding patients, we should cross match early and aim to give the third fluid bolus as a blood transfusion. We also need to think about other concurrent treatment, and with all bleeding shock patients alongside fluid resuscitation, we need to prioritize stopping the bleeding. This is important. This is very important. We need to think about stop bleeding. A 7-year-old child presents with signs and symptoms of lower respiratory tract infection. She weighs 18 kg and her initial vital signs are heart rate 150 per minute, blood pressure 80 over 30, respiratory rate 48 per minute, and temperature of 39 degrees Celsius. What initial emergency fluids would you give this child and how much? This child has signs of sepsis which require immediate attention. In children, the fluid resuscitation bolus is 20 ml per kg. So the child needs 20 ml multiplied by 18 kilos, a total of 360 ml of either normal saline or ringer latex. There's no need to give half normal saline 5% dose in an emergency to children. All patients can receive normal saline as emergency fluid bolus. It is always important to consider the urgent treatment of a circulation problems, and in this case, antibiotics are also indicated and need to be given as quickly as possible to improve chances of survival from sepsis. This is 20-year-old man has had allergic reaction to penicillin. Her weight 60 kilos and his initial vital signs are heart rate of 130 per minute, blood pressure of 70/20, respiratory rate 30 per minute, and temperature 37. You can see from the photo that he has angioedema to his lips. What emergency fluid would you give this patient and how much? This man has signs of a severe allergic reaction or anaphylaxis and requires immediate attention. The emergency fluid resuscitation should be with 1 liter bolus of normal saline or ringer lactate, but as with all patients we need to consider the cause of shock and other concurrent treatments. In this case, as the patient is having an anaphylactic reaction, we also need to give IM adrenaline 0.5 milligram. The key point of fluid resuscitation are to give a bolus of normal saline or Ringer's lactate. This can be repeated if there is no clinical improvement on reassessment of the patient. In children, the bolus is 20 ml per kilo, and in adults, it is 1 liter batch. There are some exceptions to giving to this amount as well as in shock. This includes severe acute malnutrition, where a shocked child should receive a 15 ml per kilo bolus, and in the trauma, a cardiogenic shock where 10 ml per kg is recommended. Even in cardiogenic shock, patients can often be fluid depleted, and 10 ml per kg fluid bolus can increase filling pressures in the heart and in turn improve cardiac output. It's very important to look for the cause of shock and not to forget to give other treatments simultaneously with IV fluid to successfully resuscitate the patient. Burns are special circumstances for fluid management. A 10-year-old child presents with a 50% total body surface area scale to her torso. She is 22 kg. The burn occurred at 7:30 a.m. that morning. She presents to the referral hospital at 11:30. What fluids would you prescribe for the next 24 hours? There is a special formula for calculating fluid management in burns patients. Burn can result in large amount of fluid loss, and this needs to be anticipated and treated in the bowels. We need to use a special formula called Parkland formula, to calculate how much fluid the patient will need for the first 24 hours after the burn. This formula is 4 ml multiplied by the total body surface area, percentage multiplied by the weight in kilo. Half this calculated volume should be given in the first 8 hours after the burns, which is why it is important to know the timing of the injury. The other half is given more slowly over the next 16 hours. This amount of fluid needs to be given in addition to maintenance fluid. Strict monitoring fluid balance is essential because the formula is just an estimate of fluid requirements, and it may well be that the patient requires more than this. This is why hourly urine output is necessary for all hospitalized burn patients, especially in the first 24 hours where the largest loss of fluid occurs. It's very important to monitor fluid balance. How would you calculate this 22 kilo child maintenance fluid? So for this child maintenance fluid, it can be calculated as 100 ml per kilo for the first 10 kilo plus 50 ml per kilo for the next 10 kilos plus 20 ml multiplied by 2 for the 2 kilos about 20 kilos. This is a total 1,540 ml of hard normal saline, 50% distilled for 1 day. In addition to this, in the first 24 hours, the child will also need her Parkland formula fluid as extra. What is the Parkland formula for this child? It is 4 ml multiplied by 15% total body surface area burns multiplied by 22 kilos, which is equal 1,320 ml of normal saline in the first 24 hours. As the burn occurs at 7:30 a.m., we should give half this volume, 660 ml, from 11:30 to 15:30, so that it is given the first 8 hours after the burn has occurred. The IV fluid will be started 3 hours after the burn occurred, when the child presents to the hospital. So the first half needs to be actually be given over a 5-hour period. The next 660 ml can be given over 16 hours from 15:30 to 7:30 a.m. the following day. The key points in burns fluid management are, firstly, the Parkland formula. This formula gives the volume of normal saline to be given over the first 24 hours following the burns. We can calculate this by multiplying 4 ml by the total body surface area of burns percentage and by the weight in kilos. It is important to know the timing of the burn is in order to give the correct amount of fluid, especially in the first 8 hours. Thank you very much for your attention.